She is a neurointerventionalist and stroke surgeon and is an assistant professor at Columbia University College of Physicians and Surgeons and works as an attending physician in northern New Jersey at the Valley Hospital and at St. Joseph's Regional Medical Center. She's going to be talking about probably a very underappreciated diagnosis in traumatic brain injury and trauma in general, which is blunt cerebrovascular injury.
Thank you. Thanks for having me. Yes, this is a very rare disease. Only about 1 in 1,000 trauma admissions in the United States are diagnosed with blunt cerebrovascular injury from trauma. And unfortunately, often the outcome, however, are devastating, such as in this 23-year-old gentleman who was skiing with his friends. The bad conditions were pretty bad. He veered off the slope. He was the last one to ski. No one saw him really what happened. It took a long time to find him. Once they found him, it was combative. He wasn't moving much. There seemed to have been a fracture of his leg. He was intubated. He was airlifted into the next trauma center. A CT of the head was done. It was normal. A C-spine CT was done. Showed a C3 fracture. He then proceeded for preparation for surgery for fixing his leg. He remained intubated after the surgery. And on day 2, the nurse noted that he wasn't moving. In the intensive care unit, we called the trauma resident. The trauma resident said, get a CT of the head. They got a CT of the head, and there was a huge brainstem and cerebellar stroke. She called back the trauma resident, and the trauma resident said no. So this case is going to illustrate a couple of points. How does this injury kind of arise, and is there a way of screening for it before actually people get a devastating outcome? Now we think it occurs from rapid deceleration with hyperextension and rotation of your head, as well as hyperflexion or a direct blow against it. No one really knows exactly what happens, but it's safe to say that it probably the artery gets stretched or linked in some form where an intimal injury occurs. I don't have my doesn't work. Okay, so that would be that intimal injury, and the blood will then go intramural into the wall of the artery, causing an intramural hematoma. Now that could be pretty severe to that point where that artery gets occluded, and the last thing you can form a dissection flap. It can even, if it goes through the muscular layer into the fibrous tissues layer, even a pseudoaneurysm, or it can get completely transected. Well, the important point to make here is that this type of injury probably releases some prothrombotic factors that then cause a fibrin-rich thrombus to form, and that thrombus, in all kinds of scenarios, then will travel up to the brain and causing a stroke. And the important point to make here is that this is not something that usually occurs at the same time. There is a delay. It's usually 1 to 3 days after that type of injury has occurred. And so there is a time window where we could screen and identify patients that had sustained this type of injury. We do know from published data that if you quote-unquote screen 48 hours after the injury, most of these kind of screenings occur because there is already a neurological deficit on hand, and that might be too late. So there are different grades of these kind of injuries because not any injury is alike. There is a Denver sort of classification of grade 1 to 5. A grade 1 would be one of the very minimal injuries where you just see sort of intramural hematoma in the artery, making it very irregular. These are at the least likely risk of having a stroke. And this can also occur in the vertebral arteries, so you have to sort of look at all could be a grade 2 injury with a dissection flap. You can see the artery sort of creates 2 lumen. This is also seen in cross-sectional images. Another example of a grade 2 injury with a cerebral stroke here, and also confirmed on angiography. This is a grade 2 injury because the intraluminal stenosis is greater than 25%. And sometimes, however, you can't really classify in one way or the other because the artery can also have a pseudoaneurysm, which would be a grade 3 injury. So you see here, that would be when you have an actual bulge up the artery. That's a grade 3. We have a grade 4. That's another case of a young man with after a car accident, has a C5-6, 50% subluxation, with bilateral vertebral arteries included. And I think the point to make here is that the negative C-spine or a CT head doesn't entirely rule out this type of injury. You do have to specifically screen for it. And this is a very similar injury that my skier had, where he had his left dominant vertebral artery occluded, and this patient was more lucky. He had a small cerebral stroke. And that is a grade 5 injury where you have actually a puddle of blood underneath the skull tissue with acute extravasation. Those usually require immediate treatment. You can see here. And another one a little further down, active extravasation that can be treated with operative or endovascular methods. The key here is often to assess other injuries, and there may be limitations to what treatment method we can choose based on other injuries that the patient has, and these are best addressed in a sort of multidisciplinary discussion on what the best treatment would be. So if you look what the trauma surgeons have come up with in terms of who should be screened for, then these are sort of the patterns and presentations that are associated with high risk. This is not a class 1 recommendation, but a class 2. So anyone who presents with trauma and unexplained CT findings, anyone with a lateralized immunological deficits, now that's provided if you examine your patient. Cervical spine injuries, in particular C1-C3, so remember the skier had a C3 injury and probably should have been screened according to these guidelines. Facial fractures, mandible fractures, or skull fractures, severe epistaxis, a Horner syndrome, significant neck soft tissue injury, and neck seatbelt sign, and a history of strangulation or near hanging. Now, it used to be believed that you need some sort of massive force to dissect the artery, but it's actually can occur with minor forces as well. So you could have someone sitting in the emergency room just with a Horner syndrome from a seemingly minor injury, and that person also dissected the artery. Now, this is actually a good example of someone who has a pseudoaneurysm, and that patient presented to me in huge panic, although his complaints were some sort of non-specific head, neck pain and throat pain. He seemed to have been going through some infection. At the same time, someone screened, looked at his carotid arteries, and he found this sort of dissecting pseudoaneurysm. That patient could not recall any trauma ever in his life. We put him on aspirin, and he, this was 5 years ago, he never had any event, never had any stroke. This is more of a chronic type of injury that you don't need to fix immediately because they actually appear to be fairly benign, even though it's correct that the artery will never look the same. Actually, you put up the wrong presentation. This is my old one, not the new one. I'm sorry. I gave you my new presentation before. Thank you. Yeah, but, yeah. So when we think about screening, we do need specific tests to screen, and the sort of imaging modality that seems to be the best is a CT angiogram. It should be a multi-slice, multi-detector CT angiogram, 16 channels or higher. They can be done pretty much everywhere. They're available 24/7. And they can be done fast. However, there should be a protocol in place because they do require an additional injection. So if you have a multi-trauma patient that needs a CTA of the chest and maybe a limb, then that would be a third injection. So there needs to be some coordination. However, MRI is not feasible as a screening tool because it's not always available. There are long acquisition times, and you can screen it with someone with metal in their body. So therefore, CTA seems to be better. Cerebrovascular angiograms are held to the gold standard. However, they are often also impractical and often not really feasible to be done in someone with a lot of trauma. However, I should say that CTAs, once you screen with a CTA and it's negative for one of these better CTAs, then you can be rest assured that if the patient will not suffer any sort of injury attributable to a cerebrovascular injury as a consequence, so you're kind of done. If you do have a positive result on the CTA, we do know that about 45% of them can be false positives. And this is a recent study that was shown on 250 patients that were screened with multiple modalities. And so there is an argument that been made that if you have an unequivocal result or a positive result, then you should proceed to catheter angiogram to really define whether there is an angiogram or possibly with an MRI, if it's possible to look for intramural hematoma that's acute and fresh in the arteries. Now, how to treat? So there is no optimal management. It's not very well defined. There's surgical intervention, vascular intervention, anticoagulation, antiplatelets. There is basically only a few situations where you really need to proceed with surgical or vascular intervention. And I want to outline a couple of situations. So first of all, there is no hyperacute treatment for tande lesions. So what that means is that if you have a carotid dissection here, and then you have a large blood clot that goes into the brain and causes an occlusion there, if you can identify that very quickly, although as we saw with our trauma resident and as we heard on Tuesday, having a stroke in the hospital is sort of the worst place you can have one. However, I want you to be vigilant for that. If you, with our current knowledge, we can potentially retrieve the blood clot up to 6 hours in the anterior circulation and up to 12 hours in the posterior circulation. We sort of have a distal to proximal approach. We grade ladders first. We go up there, we retrieve the blood clot, we go through the dissected artery. On our way back, we assess. If the dissection is human and it is significant, we either angioplasty it, and we can't use spermatotics because of other injuries. If you can't use spermatotics, you can put in an acute stent. Now, if the dissection is not human significant and we have recanalized the brain, we do not do any further. And so if you look at the literature, granted that this is rare, about 25% of the time it does result in a stent placement. And there was a recent study, a recall study, that showed that that can be done with a 70% good outcome at 90 days. And so this is sort of an example of a cervical carotid stent on the way out. And this is another example of a cerebrovascular injury. It's a carotid cavernous fistula. This is a normal circulation carotid artery, little cerebral artery, and you're communicating with the crossing over because on the other side there is a hole in the carotid artery and it fills into the cavernous sinus. These can be treated very elegantly with endovascular techniques, so sort of good course through, and then replace the stent, multiple stents actually, a pathologic stent, which is sort of the newer version of the recovering stent, preserving the blood flow to the brain while treating the fistula. This is another example of active extravasation that is treated with vertebral artery takedown with coils. Also can be done fairly rapidly and safely. And this is pretty much, in my opinion, the only indications for having rapid intervention on blunt cerebrovascular injuries. While everyone else is treated medically with aspirin or with antiplatelets or antithrombotics, there's no clear guideline which one to go to. At least in the trauma literature, there seems to be a more favorable trend for heparin. However, heparin is not always feasible for other contraindications. In the neuro literature, it seems that if you suffer a dissection, it's probably antiplatelets and antithrombotics are equivalently good. I have actually shifted my practice. I used to start way more heparin than I do recently. But whatever you do, you should start early. So that's important. It should be within the first 24 to 48 hours. If you do want to prevent a stroke, and you need to continue probably for 3 to 6 months, at least that's the recommendation. The trauma surgeons also recommend repeat CTA in 7 to 10 days after the injury, because their injuries can change and work since they're if you diagnose them fairly early. So there may be a role if the patient fails medical therapy, or if the lesion somewhat changes. I had once a case where the pseudoneurus grew to like 3 centimeters, where you do want to treat it at that point. Once you go 7 to 10 days on therapy, sort of 10 days, chances are that the re-stroke risk at that time really dramatically reduces, and sort of the first 10 days where it's most critical. And so in summary, I think it pays to establish a CTA screening protocol for trauma patients based on available guidelines, and perhaps the injury that our skiers suffered could have been prevented if they had known that they had a cerebrovascular injury. If you do screen, you have to do less than 48 hours, and the sooner the better. There is data that if you screen within 12 hours, you're going to prevent more strokes than if you screen after 12 hours. Consider a catheter angiogram for positive screening results only. Consider endovascular organization for hyperacute tande lesions, as I outlined before. Treat with endothrombotic agents early. Now, this is always a discussion between multiple disciplines because of other injuries that the patient may have. But if there is a blunt injury, even now with contusions, it seems that an aspirin can be safe. And repeat a CTA 7 to 10 days after injury. There are cases where intramural hematomas, if they were mild or could resolve after that time, you could potentially take them off of medical therapy at that time. At least that's the recommendation from the trauma literature. If they have an occluded artery, you probably don't need to screen, and you don't need to repeat the CTA at 7 to not to 10 days because likely it won't be open or any different. If there are changes, you have to sort of reevaluate at that time, and then whatever treatment you're committed to continue for